We shall now go on to Rishi Swarup. He's going to share. He's a medical director and chief surgeon of Swarup Eye Center, Hyderabad, and has been the honorary secretary of Hyderabad Ophthalmic Association, has been editor publications of Telangana Ophthalmic Society, and section editor of Cornea in IJO. He has also received an amazing series of very impressive awards and gold medals. He has special interest in lamellar surgeries, and today he will give his message on how to protect the endothelium. On to you, Dr. Rishi.
Thank you to all the Ramamurtis for involving me in this wonderful webinar, and I'm learning a lot. So the mandate given to me by Shreyas was to talk about how to protect the endothelium, and I'm going to make it short. It's very difficult to follow Dr. Deepak Meru's beautiful videos. I'll just try and keep it as short and sweet as possible. There are not many videos here. So the clinical situations where you're specifically bothered about the endothelium, of course, is a situation where you do have a weak endothelium. For example, a patient who has low endothelial count or gateta, or has an actual endothelial dystrophy like a Fuchs or a PMCD kind of a situation. But then there are other situations where you can end up damaging the endothelium or tipping over an already weakened endothelium, such as a case which has a difficult cataract, a hard nucleus, a small pupil, a shallow anterior chamber, presence of pseudoexfoliation, all of things which were discussed earlier today. The other situations where we do anticipate a compromised endothelium are post-keratoplasty, any patient who's had any sort of an intraocular surgery, even patients with the angle closure glaucoma who are post-KAG, we know that these corneas can sometimes decompensate. So these are the ones we have to watch out for and specifically respect endothelium in these cases. Another entity is anybody who is elderly, because these patients have multiple problems. They have hard cataracts, small pupils, their endothelial counts are lower, and of course pseudoexfoliation is often present, and it has been shown in studies that patients with pseudoexfoliation, especially beyond the 7th decade, their endothelial counts are significantly lower compared to younger individuals without pseudoexfoliation, or equivalent age individuals without pseudoexfoliation. So why does the endothelium get damaged during cataract surgery? Of course, phacoenergy is predominantly the main culprit when you're doing phacoemulsification. But then you're using so many other things, so many other instruments are being introduced into the eye. In this video, you can see we've got 4 iris retractors. So anything can touch the endothelium. And if you're not careful, it can cut the desmoid membrane as well, and it can kind of just sweep across the endothelium and damage a lot of cells. So you have to be careful with all things that are put inside the eye. At all times, you are staying away from the endothelium. You can have chemical or toxic damage, which can sometimes even result in a TAS-like situation and can significantly damage the endothelium. So if you're especially using a new instrument or some intraocular fluid which has not been tested before, one has to be very careful. Fluidics can also play a role. So if you have, for example, if you're using an anterior chamber maintainer and if flow is directed anteriorly, it can end up, the fluid flow itself can end up damaging the endothelium. It could detach the desmoid membrane. If you have a lot of manipulations and the iris is being touched a lot, or it's been prolapsing a lot, pigment release, inflammation from, again, possibly manipulations in the eye, or if it is a uveitic eye, can of course have damage to the endothelium as well. So how do we want to kind of pick up these cases before surgery? You have to look at a lot of things, and one of the important pointers is in the history, patients will give you a history of morning blurring of vision specifically. So of course all cataracts will have blurring of vision, but if they tell you that mornings are worse, please look at their endothelium a little more carefully, look at their specular count, try to get their pachymetry, and look at the slit lamp carefully. So you might pick up an early stromal edema or a weakening of the endothelium, which could of course result in a post-operative problem. Look for other clinical signs of edema on the slit clamp. So one of the very easy ways to look for stromal edema, I'm just going to show you in the subsequent slide. And of course, you want to look for other risk factors like hard cataracts, pseudoexfoliation, etc. And finally, if you have access to the diagnostic tests like specular microscopy and pachymetry, that's always a good idea. So this is what I wanted to show you. If you are able to see in this particular slit lamp picture, the central stroma is as thick as the peripheral stroma. In a normal cornea, the central cornea is thinner than the peripheral cornea. And so on slit lamp, one of the easy ways to pick up early edema. Now here you don't have ground glass haze, you don't have Descemet's poles, but you can make out this central stromal edema by looking at the differential thickness of the cornea. And of course, you can compare it to the other eye also if one eye has more edema than the other. So this is one of the easy ways of picking up stromal edema. And why is that important? Because stromal edema comes before epithelial edema in endothelial decompensation. So you want to look for early endothelial decompensation by looking at the thickness of the stroma. There you go. You can see these arrows representing the same thing. Of course, you have to look at the endothelium. This is a specular reflex of the endothelium. Everyone should know how to see the specular reflex. It's very simple. And you should be able to see gutata. You can even see, if you have a higher magnification on your slit lamp, you can even see the pattern of endothelial cells. And if you see an abnormality, then that will give you a clue. Specular microscopy, of course, there are lots of parameters. I'm not going to go into these, but you want to specifically look at the count and the gutata, and of course the pleomorphism and the polymegathism. All of those will tell you that whether endothelium is healthy or not. And all of these also have a pachymetry. So look at the pachymetry, and if your cornea is thick, that again is an indicator that your cornea's endothelium is not healthy. So when you're looking at a compromised cornea, you're looking at three scenarios: either guttate changes, or just isolated stromal edema like I showed you in that clinical photograph, or you're having stromal edema with epithelial edema. So the first category is the one where you can probably get away with only phacoemulsification, but the moment you start getting clinical edema, even if it's stromal edema, I think one must start looking at a triple procedure rather than just doing a cataract surgery. So this is the algorithm that I follow. Guttate changes, no edema, and if the patient doesn't give any history of morning blurring of vision, just phaco with explained prognosis. The moment we have a clinical edema, or if the pachymetry is, if you have mild edema but no clinical edema and pachy is less than 50, again phaco, but explain that you might need an endothelial keratoplasty. And if you have clinical edema, then of course you want to go for a triple procedure. Intraoperatively, lots of things have to be done. You have to use the right viscoelastic in the right frequency, and maybe a combination of viscoelastic. You have to use the right intraocular fluids and minimize intraocular fluids. Don't put anything that's really not necessary. So if you can avoid putting a trypan blue, avoid putting intracameral adrenaline, please avoid all of these things. Use only what is necessary, because anything can possibly further damage the endothelium. You want to minimize the time of phacoemulsification. So you want to cut down, you want to put the settings optimally. You might want to use pulse settings, hyperpulse settings. You want to reduce the on time, whatever. For the cataract, whatever you think will reduce the phaco time and phaco energy, that's the one you want to put. And at all times, respect the endothelium. Keep putting in viscoelastic, stay away from the endothelium, and keep deepening the anterior chamber. Intraocular fluids, special intraocular fluids are available for weak corneas like BSS Plus. They have appropriate additives which make it more close to the aqueous humor. There have been contradictory studies as to whether it really helps or not, but it's definitely not worse than having a regular BSS or ringalactate. So if you have access to this and the patient can afford it, please go ahead and use it. But of course, cost is a consideration. Like I said, OVD is probably the main thing that you want to look at, and you either want to use a viscoadaptive OVD like Viscoat or any other chondroitin sulfate, or you want to use a combination of a soft shell and a combination of cohesive and dispersive viscoelastic, which is called a soft shell technique. It will be a combination of both deepening of anterior chamber as well as coating of all the intraocular structures, specifically the endothelium. Not just using the endothelium, the OVD, but also keep putting it back again and again. So every few steps, especially if your phacoemulsification is lasting longer, keep going back and putting some more viscoelastic, because you want to keep the endothelium coated at all times so that it remains protected. Phacoemulsification, we all know we want to minimize the phaco time, so you want to stay as away from the endothelium also while doing the phacoemulsification. So do an in the back phacoemulsification. low and slow, no dramatic drastic movements, efficient phaco settings, so appropriate to the nucleus and the cataract. And you want the right fluidics. You don't want too much of fluctuation of the anterior chamber because that also can cause damage to the endothelium. And if possible, use a new tip because that will be more efficient in the cutting. One of the compromised endothelial situations that I often come across is a post-graft situation. So one of the additional things that you want to do in such an eye is try to make your incision outside the graft. That will damage less endothelium. And of course, the rest of the maneuvers would be similar to what I told you earlier. Like Dr. Deepak mentioned in the previous talk, there's no shame. Shift to other techniques if you think they're going to be more endothelium friendly. I often use a manual small incision cataract surgery, especially in a post-graft scenario. In my hands, this gives a glistening cornea in the first post-operative day. So please go ahead and do whatever technique you think is the most friendly to your cornea. Anticipate post-operative edema in these cases. Often you will have striate keratopathy, but that settles. If it's not settling by a month, then you probably are looking at either an endothelial decompensation. And again, look for a Descemet's detachment also in these cases if you have edema. These cases are more prone for developing Descemet's detachment, patients who have catheta. So you might need to do some sort of an intervention for those as well. So take home points, respect endothelium and it will reward you with a post-operative glistening cornea. Proper preoperative evaluation has to be done to pick up the cases that are at risk and then use appropriate measures for these cases. And phaco energy should be directed away from the endothelium and all instrumentation, again, away from the cornea. The cornea is a touch me not. Thank you.
Well, Rishi, you have tried to cover most of the points, and I like the presentation. I only want to add one point for the general public. Now, whenever you have a cornea with such weak endothelium, and you have to do a phaco, the visco-adaptive like Halon 5 is something that will go for me first, and the only time it will go, because it stays till phaco. And after that, it will not be methyl cellulose, it will always be sodium hyaluronate, because you really do not want to take any efforts to take it out. And in such cases, I would not even really bother to get it out. Even if little bit of it stays, I can always take care of it in the post-op immediate by anti-glaucoma drugs. But half the time the process of getting your chondroitin or viscoadaptive out itself can damage that. Otherwise, most of it you're covered. Good.
A very comprehensive presentation, Rishi. I mean, you really made it worth the wait. The one point I want to just add is that, so the wound hydration that we do at the end of the surgery, sometimes we do large balls of hydration and the intraocular pressure, though we might be doing the entire process of surgery at 30 millimeters of mercury, we leave at 40, 45. I think that causes a significant amount of damage and even corneal edema. So I think very gentle hydration so that we just get adequate closure. Always put a finger onto the globe at the end of the surgery to make sure that it's not too tense. I mean, I have nothing more to offer because you almost said it all.
In fact, Ramamurthy sir, you raised a very important point. Not only is it important not to overhydrate for the sake of the IOP, but also when you use those hydrocannulas to, you can induce a DMD right at the end of surgery. You've gone through a great surgery and you have a DMD. And in fact, these pseudo-exfoliation eyes which have poor endothelium, they are highly at risk of getting a DMD during surgery because, you end up having hard cataracts. And so your fluid flows should also be kept very less. I mean, I don't like to have a high flow situation when I'm doing these cataracts because, every time you go in with the instrument and come out, you're inducing a little bit of that Descemet's damage and, it can give you a, at the incision, you can start having a DMD very easily. So I think from both points of view, I think what you said makes a lot of sense.
Yes.
But very good presentation, Rishi. I mean, a lot of good clinical pearls for all ophthalmologists without going into technology too much.
Thank you.
And is this number so sacrosanct as far as the endothelial cell count is concerned? I have seen corneas with 800, 900, which I mean, so right now, I'm not a cornea.
I think the corneal number doesn't matter as much as the pachymetry, in my opinion. The pachymetry is more of a reflection of the function. functional health of the endothelium?
I think, Rishi, it will be a more of a morphology of cells which are important in these cases.
Yes.
But if I have a patient with Fuchs endothelial dystrophy, these cases will definitely have a more impact on endothelium. And you rightly pointed out very nicely the steps and screening of these patients. I think one important thing I normally stress with my students is to take a very good consent from these patients and counseling that they may require subsequent surgery because endothelium may not recover. And all my patients where I have poor endothelium or a compromised endothelium, we start them immediately post-op with the hyperosmotic agents. And especially if you have a Muro, which is a imported variety of hyperosmotic drops, that works wonderfully well in the initial phase, and the recovery of edema is also faster in these cases. So that should also be stressed. Apart from the inflammation control, you can have some sort of a thing which can take away the fluid from the stoma, and patients' visual acuity recovery is faster in these cases. And rightly stressed, if you have an endothelium which is not recovering the stomal edema for more than 1 or 2 months, then just wait for another 1 month or so before doing a DMEC or DSEC in these patients. And don't jump for a DMEC DSEC with the request of your colleague. I've had I've burned my hands with my phaco surgeon requesting me. I had operated my uncle and the endothelium is not recovering. We do the DMEC DSEC in this patient. Within a week or 2 weeks of their surgery, and I had patient with the TARS, and I did a surgery, and the entire thing was so backfiring on us. So you should give enough time for eye to cool down and observe these patients, control glaucoma inflammation, then think of doing a secondary procedure in these patients. But doing phaco, what Dr. Ramamurthy is saying, sometimes is very rewarding for these patients. And we know that not everybody has access to endothelial transplant surgery. If keratoplasty can be delayed for years, sometimes these patients do well 2 years, 3 years, 5 years down the line. And that's a saving enough time for subsequent keratoplasty.
Yeah, and now we have ROC inhibitors also in India,
Yeah.
so it might possibly work.
I think that brings us to an end.
Can I just add something?
Yeah, please.
Yes. So the other thing I like to do for these eyes with weak endothelium is actually to prevent that desmate detachment that happens so easily, is to widen the internal lip of that wound, so that when you maneuver your phaco tip, it does not actually detach the desmates, because usually the desmate detachment happens very easily when the endothelium is weak. The other point is that if you're doing a femtocataract, which is advantageous of course for these eyes, because that would reduce the effective phaco time, is that you could actually visco-float up that capsulotomy disc against the endothelium, which is already partially protected with some visco, and that can remain adherent in the center and protect the central cornea as you do your phaco, and then at the end of that, you just remove that disc of anterior capsule that's adherent there by aspiration.
I heard Dr. Ronyor speak about this, but does it in any way inhibit visualization, and does it stay in place with all the fluid percolating?
No, it doesn't. In fact, Ronyor has actually shown a case where he couldn't find the
it got stuck there.
It was stuck there, and then someone said, "Oh, have you done the DSEC or something? Because I see this round disc here," and then he realized it was stuck on the undersurface of the endothelium. Yeah.